Welcome, I'm Althea Brooks, and I'm Senior Director of Lifetime Learning in the UVA's Office of Engagement. A warm welcome to our at-home audience registered worldwide for this webinar. This program is being recorded and will be available in the Lifetime Learning's podcast library in a week or so. View Lifetime Learning's programs and online resources on our website. Download and share them with friends. Visit engagement.virginia.edu/learn. We're thrilled to have three stellar medical experts to share with us on breast cancer, latest in diagnosis, treatment, and clinical trials. Should you have a question during the program, please enter it into the Q&A box at the bottom of your screen. Our panel will attempt to answer as many questions as time permits. Now allow me to briefly introduce our moderator for today. Christiana Brenin, MD, is Associate Professor of Medicine in the Hematology and Oncology Department at UVA's School of Medicine and Medical Director of the Breast Cancer Care Center at UVA Health. Her practice focuses on the treatment of patients and localized and metastatic breast cancer. She's particularly interested in the impact of exercise during cancer treatment and ways to preserve a healthy heart during and after treatment. Please join me in thanking and welcoming this esteemed panel to speak with us today. The microphone is all yours, Dr. Brenin. Welcome.
So welcome, everybody, and thank you for being here today. It's great to see everybody on this Breast Cancer Awareness Month event. We have record registration this year. Hopefully there'll be record attendance as well. I'm here today with two of my colleagues, Dr. Trish Millard, Associate Professor of Medicine in the Department of Medicine by the Division of Hematology Oncology at UVA, and she's a breast medical oncologist at the University of Virginia, and Dr. Shayna Showalter, Professor of Surgery, and she's one of our surgical oncologists at the University of Virginia, breast surgical oncologists. So what we'd like to do today is we're happy to share information about breast cancer treatment at UVA and just about the UVA Breast Care Center, but also we're going to do a brief presentation, and we hope to leave 10 minutes at the end to allow time for audience questions so that we can answer them in real time. So as I was reflecting about my presentation today and what we're going to talk about, I was thinking back at the years that I have been here at UVA, which is really since 2002. And the UVA Cancer Center was founded back in 1984. It achieved NCI designation, National Cancer Institute designation, 1987. And in 2004 is when the first breast care center opened in the West Complex, where the old hospital is, the brick building. Emily Currick Clinical Cancer Center opened in 2011. In 2017, the breast center achieved NAPBC accreditation. And then in 2020 is when the new breast center opened at Pantops, which is our current location. We've been there now for 5 years. In 2022, the UVA Cancer Center achieved comprehensive cancer center designation. And then in 2025, just a few months ago, the UVA Cancer Center at Pantops opened up in the same building where the Breast Cancer Center is, but it's not on the main campus. It's off-site. And this is what our building looks like. This building over here is the building that the Cancer Center is in. The entire second floor is the Breast Care Center. On one end, we have radiology and breast imaging, and the clinics are also kind of in the middle. And on the other end, there used to be the infusion center and some offices, but now on the third floor is where the infusion center has been moved to. And we have 40 infusion beds on the third floor, along with some other medical oncology clinics on the opposite side of the third floor who also utilize the infusion services. Everything is under one roof, ground level parking, as you can see, easy access, right off of 64. It includes all specialties in the same center from the standpoint of breast cancer care. And we also have the Florist Boutique, a positive image boutique for patients to feel good and look even better. You can get all of your breast prosthesis, wigs, any sort of equipment that you might need to help you feel better during cancer treatment. So what is special about the Breast Care Center at UVA? We are a very team-based approach group of people. We provide care as one big unit. Our providers have been there for a very long time. We have been working together and know each other very well. There's been very little to no turnover in the providers in our breast care center. And all we do all day is just treat breast cancer. That is all we know, but we know that very well. We also have a multidisciplinary conference that we all join on Fridays, and we present, I would say 90% of the patients that show up at UVA are presented in that conference. And in that conference, used to be in person, and then with COVID, it became virtual, and now we've kept it virtual because it works so well virtually. But we have about 30 people in that room. They're breast medical oncologists, surgical oncologists, radiation oncologists, radiologists, pathologists, genetic counselors, trainees, residents, medical students, social workers. There's dietitians. Everybody's in that conference every Friday. So it really helps put our heads together and to help look at all the images and all the pathology and decide on a treatment plan for every patient. Our program has really grown from 200 to 600 new breast cancer cases per year in the past 10 years, and we have the very latest screening modalities in the same center. We'll talk about those in a little bit, but just suffice it to say, we also have bone density testing in the same building. And we do offer clinical trials right at that center, along with robust support services that are right on site. And I will ask Dr. Millard maybe to talk a little bit about our supportive care services.
Yes, so an important part of what we do at the UVA Breast Care Center is make sure to not only provide superior medical and surgical treatments, but also focus on the other parts of a person that are important when you're going through breast cancer diagnosis and treatment. And so shown on this slide here are many different examples of services that we have within the building or easily referable from the building. I'll highlight just a few. We have our physical medicine and rehab physician who is a lymphedema expert and works closely with a team of physical therapists and massage therapists right in the breast center who also do, scar tissue work and the like. We have counseling services and social work services on site and available. One of the very popular services we have is our breast center dietitian, our nutritionist, who I believe may be listening today and have to give a quick shout out. Happy birthday, Dana. And the next service I'd like to highlight is our cold cap therapy. So cold capping is something that patients going through breast cancer chemotherapy utilize to try to lessen the chances of chemotherapy-induced hair loss. There's been a bit of this in the news recently. There's been recent legislation in New York that is requiring that insurance providers are covering this. So here at UVA, we have been using cold capping for many years now. Our current device is called the Paxman cold cap. And this is an FDA-approved device, which, as you can see in the picture here, when you come for your chemotherapy treatment, essentially during your infusion, you wear a cap that freezes the hair follicles, lessens how much chemotherapy they take up, and therefore lessens the chances of you losing your hair while going through chemotherapy. So a really nice option for our patients. Losing your hair, while in some ways may not seem like the most life-threatening part of this experience, it really is important for your sense of who you are, how you portray yourself to others around you. And so having the option to potentially retain your hair during treatment, I think is really nice.
Great. In terms of our program, there's been substantial growth, but what is special about the program at UVA is the nurse navigation system that we have. We have a nurse that meets patients at the time of diagnosis. If a patient comes in and gets a mammogram and there's a biopsy shows cancer, the first person that they're going to come in contact with is going to be the nurse navigator. She helps patients throughout their decision-making process. She's there by their side, step by step with them. They also help patients that are being referred from the outside, who are diagnosed on the outside, and they help obtain all of their outside information, coordinate appointments. If they're coming from far away, they might be able to see a medical oncologist, a surgical oncologist, a plastic surgeon, genetic counselor, all on the same day, potentially even on the same day in the same building. So they are the point of contact for any subsequent questions that come up, and they guide patients through their process. We have that new 40-bed infusion center under the same roof, so access is not difficult. You can see your doctor and get treated on the same day. And we have a survivorship care program with 3 breast cancer trained advanced practice providers. Breast cancer patients are usually diagnosed and treated with their medical oncologist and surgical oncologist, but after a few years, after their surgery, chemotherapy, and endocrine therapy, surgery, chemotherapy, and radiation therapy is completed, and they're just on endocrine therapy or on no therapy, they then oftentimes get graduated to our survivorship care program that is run by the advanced practice providers. They work right by our side. So if there's any question on any given day and they need help and they need somebody to see a patient, lay hands on a patient, one of us is there at all times available to see patients with them. I'm going to pass it on to Dr. Showalter to talk a little bit about the latest screening modalities, and then to highlight the other surgical programs that are available at the Breast Care Center. And maybe, if you could, maybe walk us through what a day in the life of a breast cancer patient coming to UVA might look like.
Yeah, sure. So we'll talk a little bit more about breast cancer screening in a few slides, but needless to say, we do have all of the latest screening modalities in the breast care center, other than our breast MRIs, which are located off-site. We really believe in, and I think you'll hear this as we go through this talk, is individualized care for each patient. And this comes even at the very beginning in regard to breast cancer screening. So we take each patient's risk, their breast density into consideration when making a screening plan. And like I said, we'll talk about that a little bit more later on. Some of the newest and surgical techniques, we have always been offering oncoplastic surgery, which is a way for women to, with larger breasts or larger breast cancers to preserve their breasts. We oftentimes do this in conjunction with our fellowship trained plastic surgeons. One of the newer techniques that we're offering is lymphatic surgery, and that is a wonderful option for women that have to have all of their lymph nodes removed from under their arm at the time of surgery, and then most likely will also need radiation therapy. Both of those treatments, while necessary, also lead to a very large risk of lymphedema. And so lymphatic surgery is a way for the plastic surgeons to actually reconnect some of the lymphatic vessels to the veins in that area and drastically decrease the risk of lymphedema. So we are just starting to offer that this past year and are very excited to be able to offer that to our patients. I think to truly understand the breast center, you have to visit the space. But just to give a sense of it, I'm in the breast clinic or the breast care center every Tuesday. I start my morning out by walking into the radiology department, which is right in this near our offices. Why we have several fellowship trained breast radiologists, meaning all they do all day, every day is look at breast imaging. And I will start my day by reviewing all of my new cancer patients in person with one of the radiologists. I then walk down the hall where our clinic is, where I work side by side with a wonderful breast care coordinator nurse who helps with the treatment of my patients. But the most amazing part is that all of us are in that same hallway. So 2 steps down from me is the medical oncologist. There's also a plastic surgeon that sees patients on the same day. We mentioned the nutritionists and the physical medicine doctors. But what that really allows us to do is to, in real time, make multidisciplinary plans for our patients, while also providing convenience for them in terms of them being able to see all of us in the same space.
Great. We also have a cardio-oncology program that we are trying to develop. We oftentimes refer patients to cardiology. Breast cancer patients, as women, I guess, as they age and our estrogen levels go down, the risk of heart disease goes up. But then also the treatments that we give can be cardiotoxic. Some of the chemotherapy can be cardiotoxic, although we're trying to steer away from a lot of those agents nowadays. And also the endocrine therapy can cause significant increased risk of long-term cardiotoxicity. So we're trying to develop a cardio-oncology program that is going to be within the building with hopefully echo or heart ultrasound imaging within the building, cardiology clinic within the building, and to be able to offer this niche specialty and support and care to our patients throughout their treatments. We oftentimes make day of decisions based on somebody's cardiac function, so it's always good to have a collaborating cardiologists within reach. Maybe Dr. Millard can talk to us a little bit about genomic profiling.
Yes, I think that's a nice lead in to the next slide that we have, which is highlighting that what I consider actually to be one of the important advances in the field of breast cancer worth highlighting today, which is that breast cancer treatment really no longer should be one size fits all. There were a lot of treatment paradigms that were created 20, 30 years ago that were really important for the time, but now the treatment of breast cancer really needs to be tailored to the individual patient in front of us, understanding what is their personal health, what are their individual risk factors, how risky is their cancer, how aggressive or not aggressive is their cancer, and along with that, figuring out who needs escalated or more intensive treatment, but who actually needs less intensive treatment and is likely to do well. So an example of this would be using genomic testing, which is basically terminology that is describing sending gene testing of the tumor itself. So we talk about genetic testing of our bodies to know what are our hereditary risks. We can also check the genes of the tumor. And in particular, for example, in the estrogen type of breast cancer, the hormone receptor positive breast cancer, we can test the genes of the tumor to tell us, is this an aggressive type of estrogen-driven breast cancer where chemotherapy is going to be helpful in lowering your risk of recurrence? Or is this in fact a very slow-growing, lower-risk estrogen-driven breast cancer where chemotherapy is actually proven not to be helpful or needed and can be safely left out of the treatment approach in that case? So this is a nice example of what is being used more and more across all stages of breast cancer. A flip to that, I guess, would be that, again, as we're tailoring to the individual, we do know that some patients are high risk and that these patients are going to need newer or more things added to their treatment approach. And so some examples of these are some pills that are used in the treatment of the hormone-driven type of breast cancer. And on this slide to start, I have the CDK4/6 inhibitors, long terminology, but basically those are targeted therapy pills that work to treat breast cancer when added to the estrogen blocking pills. So these, there's two medicines in this case shown on the slide here, ribociclib and abemaciclib. Again, these are pill treatments that can be added to the estrogen blockers that patients take in high-risk breast cancer and have been shown to lower the chances of developing metastatic breast cancer down the road. So both are FDA approved and being used for the high-risk patients as an improvement in our treatment pathway for them. For other patients, we have a newer class of medicine. So shown here, it says oral SERDs. What that means is, as shown, selective estrogen receptor degraders. So our traditional pill endocrine therapy works by either lowering or blocking estrogen. Well, this is a new type of pill therapy that can actually break down the estrogen receptor or protein that these cancer cells express. This class of pills we're using commonly now in the stage 4 setting for estrogen-driven breast cancers. And currently at UVA, we're part of 2 large clinical trials investigating if these pills can be used in early stage high-risk patients. And perhaps, I'm trying to understand if they're in fact better than some of the traditional medications like tamoxifen or the aromatase inhibitors, letrozole and anastrozole, exemestane that you may have heard or been on or had friends and family be on.
Terrific. As mentioned earlier, we offer clinical trials at UVA. There are, even at the breast care center on site, there are so many, it's very difficult to go through them all, obviously, but I think I'd like to highlight just a few of them. There's a couple of treatment trials and a couple of exercise-based trials that I thought we'll talk about. And Dr. Showalter will take us through some of the treatment trials, and Dr. Millard will take us through some of the exercise-based trials.
Great. So the clinical trials that I run, that I think you're going to hear the theme or have heard the theme, is really centered on individualizing the treatment of early stage breast cancer. So this means finding treatments that give the best possible cancer outcomes, but also taking into consideration patients' preferences and priorities. We certainly don't have time to review all of the nuances of the treatment of early stage breast cancer, but in order to understand these trials, you really do need to understand the very basics of the treatment of early stage breast cancer. So the typical treatment means a lumpectomy, which is surgery to remove the area of cancer in the breast, but leaving the rest of the breast behind, followed by radiation. In its traditional form, this is about 4 to 5 weeks of daily treatments, and then followed by 7 to 10 years of endocrine therapy or an anti-estrogen medication, which of course comes with its own set of side effects, including joint pain and hot flashes. For all breast cancer treatment, we want to make sure that we do the right amount, but without doing too little and risking bad outcomes, but also without doing too much. And that leads to increased side effects and interference with quality of life. So again, these trials are focused on an individualized, patient-centered approach to the treatment of early stage breast cancer. The first trial that I'm going to highlight is the Precision Breast Intraoperative Radiation Therapy Trial, or Precision Breast IORT. At UVA, we're lucky to have a one-of-a-kind brachytherapy suite in the Cancer Center. And because of this, we were able to develop a form of radiation that allows for radiation treatment at the time of breast surgery rather than those weeks of daily treatments. So we do the lumpectomy, the breast surgery, in this room, and then place a balloon catheter, like you can see in the picture, into the breast. That donut-shaped machine in this picture is actually a CAT scanner. And so what we're able to do is take CAT scan images of the patient while they're asleep during their surgery to make sure that this balloon is in the right position and that our treatment will then be able to avoid treating the heart or the skin, but really focus the treatment on the breast tissue that needs to have the radiation. And again, the patients are then having their surgery and their radiation all in one setting. We're not going to go into the details of this slide, but really what this does is compares the different types of radiation with the precision breast radiation in the first row. The takeaway for this is that it delivers a single personalized dose of radiation and therefore maximizing patient convenience, but again, avoiding radiation to healthy tissues such as the heart, lung, and skin. We first did a phase 1 feasibility trial, and then we followed this by a phase 2 trial of 358 patients. Our preliminary analysis, which was published about 2 years ago, showed very promising results. And we now have at least 5-year follow-up on all of those 358 patients. And so we are currently literally in this moment performing the final analysis from this large study and plan to present these results at an international conference this spring. The next trial I'm going to highlight is the POWER trials that were developed here at UVA by Dr. Millard and myself. Going back for 1 second to remember that the treatment of early stage breast cancer typically involves surgery, radiation, and endocrine therapy. And the radiation needs to be delivered within weeks of surgery in order to be effective. So that's a lot of treatment. And we now know that for older women, we define older women as 65 and older, it is safe to skip radiation when we know that patients are going to take the anti-estrogen medication. The question always is, though, is how do we know if a patient's going to tolerate the medication? Because if they don't, they can't go back and get radiation, and then there's a risk that they won't have had enough treatment. So in the POWER trial, we actually gave women 90 days of that medication before their surgery, not so much as a treatment, but really as a way to see if they were going to be able to tolerate it so that they could make more informed decisions after surgery. And what we found is that these 90 days really are an effective way to help patients and their surgeons make decisions about radiation therapy. In the POWER 2 trial that we have open now, patients are actually getting randomized to either getting that 90 days of treatment of the anti-estrogen medication or going straight to surgery. Both groups then will have surgery, will make a decision about radiation, and will be recommended to take the endocrine therapy. The group that takes the medication first, though, has the knowledge about their tolerance before they have to make a decision about radiation. And we hypothesize, but we don't know, which is again why this has to be part of a clinical trial, that those patients that take the medication before surgery will have less incidence of both over and under treatment, since they know whether or not they're going to tolerate the medication before they have to make a decision about radiation. So we still have years to go and hundreds of patients to enroll in the POWER2 trial, but we do believe that this trial has the potential to result in a paradigm shift in the way that we treat older women with early stage breast cancer. And hopefully what it's going to allow us to do is have treatment plans that align with patients' preferences, but also allow them to have good oncologic outcomes.
That was great. Thank you, Dr. Showalter. Maybe we can go over some of the exercise-based trials. Dr. Millard can take us through that.
Yes, so as Dr. Brenin mentioned earlier, we have the cardio-oncology program at UVA, and I actually think this is a really important part of what we're doing at the UVA Breast Care Center. So, you know, we're having improving outcomes for breast cancer patients, which means that we've got more and more patients that are living a long life after their breast cancer diagnosis, and it becomes even more important to recognize what impact this has on their longevity, on the other parts of their health, and importantly, their cardiovascular health. We know that chemotherapy and endocrine therapy can impact this system. Early menopause can put you at higher risk for cardiovascular disease. And it's a really important part of our work here is trying to not only treat that when it happens, but the consequence, but actually look to see what can we do early on to better understand the impacts on the body, how it's happening, why it's happening, and what we can do to prevent actual long-term damage. So two of the clinical trials that we have at UVA trying to understand this better are listed here. So first is the Flourish trial. I'm so grateful for so many of our patients in the last 2 years that participated in the Flourish trial. This is a study where we've actually enrolled all of planned patients, so we're in the analysis phase of it, but looked at people with breast cancer who were being treated with chemotherapy that was had the potential to be cardiotoxic, and looked at their baseline cardiovascular health, did some blood testing to understand how their immune systems and markers of inflammation in their body were looking, and then actually assigned to the participants to different groups. So within the study, we had a group of participants who were encouraged to stay active during chemotherapy, exercise at their baseline, but weren't really being monitored or prescribed anything. And then we also had a group of participants who were doing monitored stationary bike exercise and a group doing monitored walking exercise. And then at the end of their chemotherapy, we're comparing across those 3 groups to see what impact those had on some of the markers of cardiovascular disease, inflammation, and their physical testing assessments of their heart. We also have a newer study that is now enrolling patients that is a similar concept, but one step back in that it's a pilot study where we're looking at women who are being prescribed the estrogen blocking pills, the aromatase inhibitors. So many of our early stage breast cancer patients take these for 5 to 10 years after their breast cancer diagnosis. And a common symptom of that is muscle and joint aches and pain. I have patients tell me they just feel stiff, they feel achy, they feel old, and they wonder what this is doing to their bodies. So what we're doing is enrolling patients and doing baseline testing of their cardiovascular system by doing a stress test, looking at how well their lungs deliver oxygen throughout the body, muscle testing, blood tests to look at signs of aging and inflammation, and then repeating all of this assessment after they've been on the pill for several months, with the goal being that we gain this understanding and then in the future plan a second larger trial where we can add in exercise interventions or other interventions to try to lessen any impact.
That's great. And we enroll patients amongst the three, there's 3 medical oncologists, and all 3 of us enroll patients on these trials. And I cannot tell you how excited patients are to participate in an exercise-based trial. They feel like that's the part that has been neglected in their care in the past. So they're very excited to, 1, participate, and 2, to contribute, so that they know that in the future, patients undergoing breast cancer care may lead a healthier life. These trials are expensive. They cost a lot. They cost a lot in time, and they cost a lot in money. If you see here, the average cost of enrolling 1 patient in a clinical trial going from phase 1 to phase 4 is significant. And phase 1 is essentially a trial where they're trying a new medication in a human patient for the first time to assess toxicity and just make sure that it is tolerated and safe to give. Phase 2 trials are essentially trials with the drugs that have been tested that we know are safe in humans, but we're trying to figure out the perfect dose that is not too much, but just right enough, just the right amount. Phase 3 trials is when they're doing actually head-to-head comparison between standard of care treatments and the new agent that they're providing to patients when it comes to medications, or standard of care exercise and the new type of exercise that we are now offering patients. So that's a phase 3 when you're actually comparing head to head. And phase 4 are post-marketing trials. After a medication or some kind of intervention has been approved that by the Food and Drug Administration or some approving accrediting body, that then they are tested in real life just to see in the community and in an academic center, what is it like to really use this drug and how are patients tolerating it? So you see the cost can be quite significant, and the line items that go into the cost of such a clinical trial are listed below. So that is where seed funding in breast cancer research is critical. Seed funding provides early stage funding to support innovative projects and ideas. We collect preliminary data and develop a proof of concept just with ideas, and we try to come up with a trial that we think is going to be helpful to people, but we have no funding to begin the trial. So that's what seed funding is. And this initial seed funding is crucial because it helps us attract larger major grants from institutions like the NIH or the Department of Defense. I will actually, maybe Dr. Showalter or Dr. Millard, can you tell us how you have funded your trials and that you have worked on, and how has maybe philanthropy helped you in the past?
Yeah, so I can start with that one. So with the IORT trial, it was started by a pilot funded grant that I was able to obtain from the American Cancer Society. And then I was actually able to secure a large R01 grant from the NIH. So those are some of the biggest funded grants that the NIH gives. And that money has been able to pay for that trial, as well as this follow-up period that I talked about. For the POWER trials was initially funded by an NIH grant, a smaller one, but an NIH grant. But in this current environment where cancer funding is just more and more difficult to obtain, it's getting more and more challenging. So the POWER 2 trial is really essentially running based solely off of support from the UVA Cancer Center, as well as philanthropic support from some very grateful patients from both myself and Dr. Millard. So philanthropy is hugely important for our ability to continue to move forward in studying breast cancer treatments.
Dr. Millard, any other sources of funding that you may have had for your trials?
Yes, obviously I collaborate closely with Dr. Showalter, so echo some of what she said, but I just want to also give a nod because it is the philanthropic funds are very appreciative, and particularly here in our community, as I'm sure many on the call are well aware, we have the annual Women's 4 Miler, and that's been able to support some of the work that I mentioned in the exercise trials and the cardiovascular risk trials. So really think that makes a ton of sense to have a race where women go out and walk or run and participate and fundraise, and to see that feed directly back into some of the work we're doing here. It's important.
Terrific. Well, that pretty much ends the presentation portion of our talk, and I thought we would do, we collected some questions from the audience ahead of time that were sent in. Thank you so much, because it allowed us to prepare a little bit ahead of time. And we've broken down those questions into different sections, and we thought would each take a little bit of some time to answer those questions as a group, because they had similar themes. And then any additional questions that may come from the audience, we can certainly address those. We'll leave another 10 minutes at the end to address those. So first, there were some questions about diagnosis and screening, and maybe I'll have Dr. Showalter take these.
Yeah, sure. And I just real quickly, I saw a trial related question in the chat. So I can very quickly answer that. In regard to the POWER trials, somebody asked if those are open for estrogen receptor positive or negative. And that is a great question. And those trials are specific to estrogen receptor positive breast cancer patients. So in terms of diagnosis and screening, there was a lot of questions that we got about this. And I think the takeaway is that you really want to find a physician, be that your primary care physician or your gynecologist, that can really help work on an individualized breast cancer screening model, because not all patients should be screened in the same way. In the breast care center, we have all of the different modalities. So at this point, 3D mammogram or tomosynthesis should really be what all mammograms are. It's been around long enough. And so at a minimum, most women are getting a mammogram, a 3D mammogram once a year. At UVA, we typically recommend starting that at age 40, but you will hear slightly different recommendations around that. We also use ultrasound, specifically in younger patients or patients with very dense breast tissue. For high-risk patients, there are times where we will add in MRI in addition, not instead of, but in addition to mammogram, in which case each test would be done once a year, but separated by 6 months, so that those high-risk women are screened every 6 months. And then also for high-risk patients, we have something called contrast enhanced mammography, which is a way of combining contrast with a mammogram. And unlike the MRI, this can be done in the breast care center. So it's a really nice option for patients with dense breast tissue and for patients that are in increased risk. I saw another quick question that's related here is about what classifies somebody as increased risk. Typically, the definition of that is when you have a greater than 20% lifetime risk. The average woman, I think, is at high risk, because the average woman is at a 12% lifetime risk of breast cancer, but high risk is defined as 20% or greater. And we have lots of different models and ways of figuring out each woman's risk status.
Great, that's perfect. There was a bunch of questions about endocrine therapy, and I think I will take this one. And there was a general theme of which agents are you using, how long are you using them for? So let me just kind of give you a little bit of a primer on endocrine therapy. So patients patients that are hormone receptor positive will be offered endocrine therapy with either tamoxifen or an aromatase inhibitor. Tamoxifen is primarily for premenopausal women. Aromatase inhibitors are primarily for postmenopausal women. Tamoxifen can also be given in postmenopausal women, but preferably used in the premenopausal group. The duration of treatment for tamoxifen is usually 10 years. For aromatase inhibitors, it is usually 7 years. It used to be 5, it went to 10, and then back down to 7, because we did some studies looking at 7 versus 10 years, and they saw that 7 years was no worse than 10 years. So now we usually recommend 7 years of treatment, unless there's other exceptions to the story. The one thing that is important to understand as well is that there is a carryover effect. So if a patient gets treated for 5 years, the benefit really goes to 7 to 10 years. And if a patient is treated with endocrine therapy for 10 years, the benefit can go on for at least 15 years. So you're still at an advantage even when you stop your endocrine therapy. It's not like you're suddenly unprotected. A lot of patients are fearful, what's going to happen tomorrow when I don't take my endocrine therapy? The benefit carries over. And then side effects of endocrine therapy, these are tough medicines. I spend at least half my time managing patients with difficulty tolerating these medicines. Some of the menopausal symptoms are very difficult: hot flashes, sweats, weight gain, maybe a little bit of extra hair shedding, sexual side effects. And then The main one is also joint aches and pains, joint tightness and stiffness. What we usually recommend to patients is, one, stay active, make sure you're constantly moving, you're getting exercise, do not gain weight, because gaining weight is an adverse risk factor in terms of the risk of recurrence and risk of breast cancer. Always definitely try to have a healthy diet, and I think Dr. Millard will talk to that in a little bit. Also, it's important to remember that it's okay to take a break every now and then. It's not like you have to be on endocrine therapy straight through and you miss a day or a week and you're behind. Oftentimes we'll give breaks and we will treat for a period of time, and we'll say you can take a month off, you can take 2 months off, see if your body recovers, how well you feel, and then we can always switch to a different agent because they're all very equivalent. So the side effects primarily happen during the first 6 to 9 months. And if you can make it to a year, you're in a good place, because a lot of the side effects actually either patients get used to them or somehow the body habituates, your immune system kind of finds a good medium and finds a better place to be. So after a year is when you can tell whether you're going to tolerate these for good or for the whole duration or not. And the last thing on side effects that I would say is the cardiotoxicity is real. The aromatase inhibitors will increase sometimes blood pressure. They will increase the lipid profile, so cholesterol, triglycerides. So it's important to keep good heart health. So the exercise is important, making sure to stay connected with your primary care physician or see a cardiologist if needed. I'm going to move on to ductal carcinoma in situ. Dr. Showalter, you want to take this one?
Yeah, sure. And so there were several questions about ductal carcinoma in situ, which is a lot to say, so we tend to call it DCIS. DCIS is technically breast cancer, but it is stage 0 breast cancer. So as this cartoon figure depicts, in DCIS, the cancer cells have not invaded past the ducts of the breast, but it is still considered breast cancer. And so we treat it, therefore, very similarly to the way that we treat invasive breast cancer, with the big difference is that patients with DCIS are not ever going to be recommended to be treated with chemotherapy because, again, it is a pre-invasive cancer. But so the treatment is really focused on surgery, radiation, and sometimes the anti-estrogen medications that we just talked about. There are some large trials not open here at UVA, but that are now under analysis that look at the option of skipping surgery for DCIS. It is not something that we recommend at this time. And it's also important to realize that not all DCIS is created equal. So there are some that are much better behaved than others. And that's something that we talk about with patients when they receive this diagnosis, and then we're coming up with treatment plans.
Great. There were a bunch of questions on triple negative breast cancer.
Yes, I'll take this one. Triple negative breast cancer is something we didn't heavily focus on today, so glad to point out a few things about it. So unfortunately, triple negative breast cancer is the most aggressive subtype of breast cancer, and therefore warrants a very aggressive treatment approach. So that's the bad news. The good news is that actually the survival and is improving for triple negative breast cancer. So we're seeing more and more patients get through this and be successful in their treatment. And I think things to know about how we treat triple negative breast cancer is that it typically does include treatment with chemotherapy. So as I said earlier, sometimes other types don't have to have chemotherapy, but triple negative breast cancer, really, that is an important part of the treatment. But in the current day, what is making the outcomes better is that most patients in the early stage setting are going to not only have chemotherapy, but also have immunotherapy. So immunotherapy is a newer type of cancer treatment. It's typically IV medicine that actually turns on your immune system to attack cancer cells along with the chemotherapy killing cancer cells. So a really neat way to attack cancer that's been proven effective in triple negative breast cancer. And then the other thing I'll speak to briefly that relates to some of the to a question I saw in the Q&A, I think, about what's new in treatment of metastatic breast cancer. Important for triple negative breast cancer is a new type of chemotherapy medications we have called antibody drug conjugates. So that's a long mouthful, but what that means is, again, getting back to the idea of targeted therapy, we have identify targets on the cancer cells and make antibodies that will bind to them. And then the chemotherapy is attached to it and actually goes inside the cell and kills the cancer cell from the inside out. So when I explain this to patients, they're oftentimes, I've had multiple patients say, oh, so it's a sneak attack. And I think that's a great analogy for it. And it's a really nice way to get a real potent chemo dose right where you want it and not in the rest of the body where you don't want it. So there are several new antibody drug conjugates that we use for stage 4 breast cancer that are also being studied in early stage breast cancer as well.
Great. And then we had a bunch of questions on prevention, risk, and genetics. I think Dr. Millard will take that one as well.
Yeah, so another thing that I think is important to focus on, a lot of patients will ask me, what can I do? I hear about the medicines, I'll take the medicines, but what can I do to lower my risk of breast cancer? And this is where there is actually a lot of decent quality data looking at things like nutrition and exercise. So there's so many different diets and information out there in the in the era of the internet, but the diet lifestyle that really has the best evidence for reducing your breast cancer recurrence risk is a Mediterranean style diet. So those tend to be low in processed foods, high in lean proteins like fish and poultry, like legumes, high in healthy fats, and high in fruits and vegetables, low in processed sugar. So that's something that we encourage our patients to work towards. Exercise, as we've been said multiple times, is an important part, maintaining a healthy weight along with that. And then briefly on the genetics of breast cancer. So a relatively small proportion of patients with breast cancer are found to have a hereditary mutation. The BRCA or BRCA is certainly the most common, but we actually do have many other identified genes that can lead to hereditary breast cancer. I think genetic testing is fairly interesting because when it was first becoming available, it was very cumbersome. The technology was very difficult to do this. It was very expensive. It wasn't well covered by insurance. And that actually has greatly changed over the last decade, so that now these tests are less cumbersome. They're therefore less expensive. They're better covered by insurance. And it's becoming more and more accessible for patients that are interested, so that, yes, certainly those who have a strong family history should be tested, but actually for many of our patients diagnosed with breast cancer, it's a much more accessible test to find out if they carry any kind of hereditary mutation.
Terrific. I think this brings us to the end of the pre-sent questions, and I would like to maybe now, first of all, thank our panelists for being here and taking the time to present this this information, but also to address some of the outside questions that are coming in. I had a little bit of a difficult time looking through the questions, but I'm looking at them now, and there's a few that are just about endocrine therapy that I thought I would take. One of them is about tamoxifen and uterine polyps. Tamoxifen does increase the lining of the uterus, so will cause endometrial thickening, and it can increase the risk of uterine polyps. It's okay to have a uterine polyp, but it does increase the risk of uterine cancer as well. The risk of uterine cancer is small. It's about 1 in 1,000. It's not that high. But that being said, it is something that we do take seriously. It is usually a very early stage cancer. It is picked up by postmenopausal bleeding. It happens primarily to women who have been on tamoxifen for a long time, 5 years or so, in their 60s. And it is easily cured with surgery. Now, it's surgery, yes, but it is not a life-threatening cancer usually. So the polyps can happen, the cancer can happen. And then there was another question about aromatase inhibitors causing long-term side effects. Aromatase inhibitors do not actually cause joint destruction. It just causes inflammation around your joints. But once you come off the aromatase inhibitors, all of those side effects should get better, even the elevated lipid profile. Now, if you have elevated lipid profile and you have hypertension and you suffer a cardiac event or a stroke while you're on the endocrine therapy, then obviously you can have long-term side effects of that. But the actual elevation of the lipid profile, the blood pressure, the joint inflammation, all that should get better when you come off your endocrine therapy. So there's no long-term side effects that should remain.
I saw one that I'll take now, that somebody asked, do you allow patients to use vaginal estrogen to prevent vaginal atrophy and UTIs when they're on an aromatase inhibitor? So I like that question. I think it's timely. The endocrine therapy treatments that we use to block estrogen certainly contribute to vaginal dryness, which can cause a number of problems such as vaginal atrophy, as well as recurrent urinary tract infections. So it can be quite problematic. And historically, I think there was concern about using low dose topical vaginal estrogen, but we now do have data that suggests that that is a safe use of estrogen for our estrogen receptor positive breast cancer patients. And so we do allow our patients typically to use low dose vaginal estrogen, because very, very minimal amounts of that are actually absorbed into the blood system. And so it's really a local treatment, can really help the symptoms, can also help keep patients on their endocrine therapy for longer, reaching their goal duration.
I saw a couple questions related to the POWER trial. One of them, which I think is a great question, says, in the POWER 2 trial, what is the risk associated with delayed surgery if you're waiting 90 days to do your surgery? And we actually know that this is completely safe. There are some cancers that we actually treat purposefully with the endocrine therapy beforehand. In the POWER trial, the purpose of the endocrine therapy is not actually to treat the cancer, but we know that it's safe. And interestingly, during COVID, when we weren't actually operating on patients with this type of cancer, we treated all of them essentially in this way with endocrine therapy until it became more safe to do these operations on lower risk patients. And now that we have several years data from that group of patients, they have done just as well as patients that we treat in the traditional way. So patients ask that question all of the time when we're talking about the POWER trial, but we feel very comfortable that both arms of the trial are a safe way of treating breast cancer. And then relatedly, somebody asked if you could share a moment in our life from research that inspired or underscored the importance of innovation in early stage breast cancer care. I have thousands of stories that kind of really hit home and make this work feel very important. In regard to the POWER trial, I had a patient who was extremely fearful of radiation. Her husband had undergone head and neck radiation, which is a very difficult treatment and much worse in ways to get through than breast radiation. And she absolutely did not want to have radiation. She enrolled in the POWER trial and really did not tolerate the endocrine therapy at all. She said to me, I'm never putting this pill in my mouth again. And so she then decided to have radiation, which was great because she would have otherwise ended up being undertreated at an increased risk of recurrence or death from breast cancer. So it was a great and like very personal story of how that trial helped a single specific patient.
I saw a few questions about GLP-1 medications and how that can be utilized in people with breast cancer. And I think that that's actually a really interesting question. In general, I think the first thing to know is that there's not currently any cause for concern of using that class of medications in breast cancer patients. So no, having breast cancer isn't a contraindication that would make me as your oncologist say that you shouldn't take it if it's otherwise appropriate for you. It is something that's being studied in women with breast cancer, patients with breast cancer, knowing how estrogen gets formed in the body. Some of it actually does come from fat cells. And so there is some, and we know that it's important for breast cancer survivors to maintain a healthy weight to keep their recurrence risk lower. So there are clinical trials, not at UVA right now, but at other places that are trying to look at this question of whether utilizing them might actually reduce your breast cancer risk.
There was a question about addressing side effects of Zometa infusions. We didn't talk about bone-targeted therapy, but a lot of the aromatase inhibitors will cause bone density loss. And so we follow bone densities at 2-year intervals, and we oftentimes recommend for patients to start taking what we call bone-targeted therapy. And bone-targeted therapy to protect their bones can be in the form of a pill called alendronate, or it can be in the form of an injection. It can be something called Prolia, which is an injection you can get twice a year, or something called Zometa or Reclast, that is a once-a-year infusion that you receive, and you can get it at the breast care center. Side effects of these agents are usually the oral agent can cause a lot of heartburn and esophagitis potentially in people who have trouble with that, but the intravenous medicines are usually well tolerated. The first few days, people can have a little bit of a flu-like illness and feel unwell, but after 48 hours, they usually should not have long-term side effects. One of the other long-term effects that we do worry about is dental problems. There's something called osteonecrosis of the jaw, and I don't want to get into the details of that, but people who have teeth pulled while they're on these bone-targeted therapies, the bone may not heal as well and as fast, so they may be left with a slowly healing open wound in their mouth. It's rare, but when it does happen, it's very sad. So we usually do tell patients to make sure to notify their dentists that they are on these agents if they're going to be having any teeth pulled. And then lower calcium levels. So we tell people to be on calcium supplements, because the way these agents work is by taking calcium from your bloodstream and putting it into your bones. So you do need to be on calcium and vitamin D supplements while you're taking these agents.
There's a question here about risk. I did mention that most women have 12% risk, but there are a variety of factors that increase risk. And so that's exactly true. We take into consideration lots of different things: family history, age, the amount of estrogen a woman has seen. So IVF treatments and hormone replacement therapy can increase the risk of breast cancer. We also know that breast density, meaning how thick the breast tissue is, can increase the risk of breast cancer in and of itself, but also dense breasts can make screening harder because the cancers can hide in the dense tissue. So breast density is a risk factor for both of those reasons. So there's several things that increase a woman's risk, and all of that is taken, again, like I said, into consideration when we're coming up with the best way to screen for breast cancer in a particular woman.
Trying to see any other questions that stand out that tend to be repetitive. That might be
one that I think I got cut off from typing, so I'll say there was a question about does alcohol consumption increase risk of breast cancer? And so yes, there is a correlation between alcohol consumption and risk of breast cancer. And the more alcohol that a person consumes per week, the greater that correlation is. So that's typically something that we recommend minimizing for our patients. Others. Our study is not currently involved in the low TAM trial, but we do commonly low dose tamoxifen, I think is what that is referring to. So like different dosing questions come up, and a lot of our endocrine therapies have standard dosing, but tamoxifen is a little bit of an exception where there is good evidence for using lower dose tamoxifen in certain instances, particularly for the stage 0 DCIS breast cancer that Dr. Showalter spoke about earlier.
I don't know if we have much time. I think it's 2:59. So I think we're going to need to bring this to closure. Thank you, everybody, for being here today, taking the time out to listen to this webinar. We are happy to be here. We are available. I think there's going to be a number and a contact information for the breast care center if anybody has an interest in making an appointment or asking further questions. We are happy to answer them. So thank you, everybody, for coming.
Thank you, doctors. What a great, informative program that you've provided us today. You have helped so many women and families. Thank you. Thank you for your time today. We appreciate you so much. And audience, thank you for tuning in from around the world. You've asked such great, thought-provoking questions. We appreciate you as well. To learn more about lifetime learning and upcoming opportunities, please go to our website. Let me highlight just a few of them before we leave today. our More Than the Score program, our lecture series before each home football game. The next program and our final for the season is Exploring the World of Vampires Through Video Games. That's on November 8th. Other upcoming programs, Copability with Bruce Holsinger on November 13th. You don't want to miss that program. 250 Years of Loving Jane Austen on December 3rd. Visit our website at engagement.virginia.edu/learn. Again, thank you, panelists. Doctors, you were fantastic. And audience, thank you for being here. Stay well, everyone.